Welcome to the debate. Today, we are navigating what might be one of the most uncomfortable yet critically important terrains in modern medicine, the lesion landscape. We're talking about the bumps, the tags, discolorations, and viruses that inhabit our skin, specifically in the genital region. It's a subject where really the medical community is deeply divided between aggressive intervention and a more conservative, hands-off approach.
And it's a landscape just riddled with anxiety, isn't it? We're looking at this tension between the urge to, cut, burn, or medicate every single anomaly versus the biological reality that the human body is just noisy. Many of these conditions are benign or self-limiting, or they're simply dormant passengers we carry with us.
So the central question we're really grappling with today is this. Where do we draw the line between a medically necessary procedure and a cosmetic concern? And maybe more importantly, are we over-treating common viral passengers like herpes simplex virus, while at the same time missing subtle scarring and potentially cancerous conditions like lichen sclerosus?
It's all about balance, and I'm here to argue for a conservative, evidence-based approach. I believe the medical system, often driven by a fear of litigation and maybe patient anxiety, pathologizes completely benign conditions. We're seeing insurance guidelines that I think rightly limit the removal of non-threatening lesions, and we're dealing with a viral stigma around herpes that vastly outstrips the actual medical risk.
And I can see why you'd think that, but let me offer a different perspective. I'm here to argue for a proactive, a vigilant approach. I believe that early identification, biopsy, and treatment, even systemic treatment, are absolutely essential. We're not just talking about bumps on the skin here. We're talking about preventing long-term sequelae like scarring, infertility, and even cancer. To me, wait and see is a dangerous game when the skin is telling us something is wrong.
Then let's get into the evidence.
Okay, so let's start with the cost of missing the diagnosis. Because the reality is, genital dermatosis are frequently misdiagnosed and just woefully undertreated. We really can't afford to be passive. If you look at the data from the U.S. Surveillance Epidemiology and End Results Program, this SEER data, the incidence of vulvar intraepithelial neoplasia, or VIN, increased more than fourfold between 1973 and 2000.
Now, just to clarify for our listeners, when we say VIN, we're talking about a precancerous condition of the vulvar skin. Is that right?
Exactly. It's the warning shot before invasive cancer. And a fourfold increase is a massive spike. To me, that rising tide is proof positive that a conservative, wait-and-see approach is failing women. We are missing the window to intervene before it becomes life-threatening.
But is it failing them, or are we just looking harder now? I mean, diagnostic criteria have changed, surveillance has increased, and frankly, I'm just not convinced by this "it might be cancer" panic for every single lesion. Benign implies harmless.
But benign does not mean symptom-free. And this is the hill I'm willing to die on today. Take lichen sclerosus, or LS. To the untrained eye, it looks like pale, thin skin, maybe a little white plaque. It's technically benign in that it isn't cancer, yet. But if you leave it unchecked, it causes what we call architectural changes.
Architectural changes is a very clinical, very gentle way of saying it erases a person's anatomy.
It is. We're talking about scarring, fusion of the labia, burying of the clitoris, and just devastating sexual dysfunction. We have data from Next Steps in Dermatology that shows topical steroids often fail in these refractory cases, yet providers are hesitant to escalate to systemic agents like retinoids or methotrexate. That hesitation leads to permanent damage. And on the viral side, with something like HSV, we know asymptomatic shedding is a major vector of transmission. So suppression therapy isn't just a personal choice, it's a public health imperative.
Well, I come at it from a different place. We have to distinguish between what is abnormal and what is actually pathological. If we look at, say, the Blue Cross Blue Shield of Massachusetts Policy 707, they are very, very clear on this. They define medical necessity rigorously. Removing lesions like skin tags, seborrheic keratoses, or nevi is explicitly considered not medically necessary unless they meet specific, severe criteria.
Come on, insurance policies are cost containment tools. They're not clinical Bibles. They're designed to save money, not to save skin.
I'd say they're guardrails against over-intervention. Look at herpes, HSV1 and HSV2. It is ubiquitous. The MSD manual notes that worldwide, HSV2 affected 520 million people in 2020. That is 500 million people. For the vast majority, up to 90%, it's either asymptomatic or incredibly mild. When we aggressively screen and treat, we often lead patients down a path of steroid phobia, unnecessary biopsies, and profound psychological distress over conditions that are largely dormant. We end up treating the anxiety, not the disease.
That's an interesting point, though. I would frame it very differently. I believe we're treating the risk. But let's dig into that insurance aspect you just brought up. You cited policy 707.
I did. Let's look at this insurance reality versus patient reality. We need to define benign. The BCBS policy 707 is quite specific. They heavily regulate CPT codes like 11-2000 for skin tags and 17,000 for the destruction of lesions.
And for the audience, CPT codes are basically the billing numbers doctors submit to get paid.
Exactly. And for these codes, the policy's stance is that unless a lesion is suspicious for malignancy, so following the ABCDE criteria, or it's causing a clear functional limitation, removal is purely cosmetic.
Okay, but let's break down those criteria. The ABCDEs, sure. Asymmetry, border, color, diameter, revolving. That's for spotting melanoma, but let's look at what functional limitation actually means in the real world, according to their own policy. It allows removal for symptomatic lesions, so pain, bleeding, or intense itching. Now, you might say a skin tag is cosmetic, but if that skin tag is on a bra line or in the groin where clothing causes recurrent trauma and bleeding, that's not cosmetic. That is a daily quality of life issue.
And if it's bleeding and catching, the policy does cover it. You just have to document the trauma. My concern is the slippery slope. The policy specifically excludes removal for appearance or personal preference. That is the key phrase. If we start billing insurance for removal of a benign seborrheic keratosis, those waxy, stuck-on barnacles of aging, because a patient finds it unsightly or distressing, we're monetizing normal skin variations. We're medicalizing aging.
But it's not about vanity. It's about diagnostic certainty. You mentioned the ABCDE criteria. But visual assessment is fallible. Even the best dermatologists get it wrong sometimes. The ACOG committee opinion explicitly states that pigmentation changes need a biopsy because you cannot know it's benign until you check. They urge clinicians to treat all patients who present with VIN. How can you treat VIN if you don't biopsy the benign-looking pigmented lesion in the first place? You're assuming it's a seborrheic keratosis. I'm saying, prove it.
Of course, if there is genuine suspicion of malignancy, a biopsy is warranted, but you're advocating for a dragnet. The priority health billing policy reinforces this. Removal is considered cosmetic unless there's clinical uncertainty or physical evidence of inflammation, like purulence or edema. We shouldn't be removing every single skin tag just in case it's the 1 in a million that isn't a skin tag. That's a huge mismanagement of resources. It's defensive medicine that just drives up costs for everyone.
I'd argue it's risk management. And that brings us to the second core area of our debate, the silent escalation. We're seeing conditions like VIN and lichen sclerosis being managed far too passively.
Passively or cautiously?
Passively. Let's look at the source from Next Steps in Dermatology. It highlights that while high-potency topical steroids are the first-line treatment for lichen sclerosis and lichen planus, they fail in refractory cases. The disease just keeps marching on.
While I acknowledge the severity of LS, it's a difficult condition. But that same source notes a survey where 50% of providers hesitate to use systemic agents like methotrexate or mycophenolate. And why? Because of the significant side effect risks.
Let's explain what systemic agents are, though. We're not talking about a cream you put on the spot. We're talking about pills or injections that suppress the entire immune system.
Exactly my point. Methotrexate is a serious drug. It can cause liver toxicity. It can suppress bone marrow, meaning your body stops making enough blood cells. Is it really responsible to jump to these heavy hitters for a skin condition that might be managed with better compliance to creams?
It's responsible if the alternative is permanent disfigurement. This hesitation, this steroid phobia or systemic phobia, leads to scarring and, crucially, to malignancy risk. LSE carries a specific, known risk of squamous cell carcinoma. The experts cited in Next Steps in Dermatology are using JAK inhibitors and IL-23 inhibitors off-label.
And JAK inhibitors are the newer class of drugs, right? They block specific inflammation pathways inside the cell.
Right. They're more targeted, and experts are using them because they recognize that the risk of untreated disease, the scarring, the cancer, the fusion of anatomy, it outweighs the risk of immunosuppression. We have to treat the patient in front of us, not the hypothetical side effect profile. If a woman's anatomy is fusing shut, you don't worry about mild nausea from methotrexate. You worry about preserving her function.
That's a compelling argument for the severe cases, I'll grant you. But have you considered the recurrence rates? The ACOG committee opinion notes that even with aggressive treatment for VIN, we're talking laser ablation or wide local excision, the recurrence rate is 30 to 50%.
Which is frustrating. Yes, of course.
It's more than frustrating. It calls the whole strategy into question. If the disease comes back half the time, even with aggressive, full-thickness epithelial destruction, are we just subjecting patients to surgical trauma without a cure? We burn the lesion off, she heals for 6 months, and then it's back. Have we actually helped her?
So what's the alternative? We do nothing? We just watch it?
No, we monitor. ACOG suggests distinct monitoring at 6 and 12 months. VIN progresses slowly. It is not a wildfire. We can watch it. We don't need to burn it off the moment it appears if we know it's so likely to return anyway. Subjecting a patient to repeated genital surgeries for a condition that might regress or stay stable is its own form of harm.
I have to strongly disagree with the watch and wait approach for VIN. ACOG urges treatment for all cases because VIN is pre-malignant. You're gambling with cancer. You're betting the patient will come back for that 6 months checkup. And you're betting the cells won't mutate faster than your schedule. But okay, let's shift to the viral side of things. This is where I feel the do-nothing approach is most prevalent and maybe most dangerous. The herpes paradox.
It is a paradox, I agree, but perhaps not in the way that you think. Let's look at the numbers. The MSD manual and the CDC data tell us HSV2 affects 1 in 6 Americans aged 14 to 49. That is massive. But the crucial point, the one that drives my advocacy for intervention, is transmission. Transmission occurs during asymptomatic shedding.
Right, and let's define that for the listener. Sure, the virus lives in the nerve root. Periodically, it travels down the nerve to the skin surface. It sheds viral particles. The person has no sore, no itch, no tingle. They feel perfectly healthy, but they are contagious.
Exactly. It's dormant in the nerve ganglia. It reacts to stress, fatigue, menstruation. It is, for billions of people worldwide, simply a part of the human condition. The MSD manual states that most people never even know they have it. If 90% are unaware and living their lives perfectly fine, why are we trying to medicalize them?
Because ignorance is not bliss. Ignorance is transmission, and specifically, ignorance is dangerous for neonates. The Women's Health Guide and MSD manual are crystal clear. Pregnant women can transmit HSV to newborns during delivery. This is potentially fatal. It causes brain damage, eye problems. We have a tool, acyclovir. We can start it at 36 weeks gestation to prevent recurrence and transmission.
I think we agree on the pregnancy management. If a woman has active lesions or a known history, of course, we manage that to protect the baby. But you seem to be arguing for broader screening and suppression in the general population.
I am, absolutely.
Well, the USPSTF, the U.S. Preventive Services Task Force, which is really the gold standard for these things, recommends against universal serologic screening for pregnant women who are asymptomatic. And why? Because the anxiety, the stigma, and the potential for family disruption of a positive test in a person who has never had a symptom, it outweighs the benefit. You are treating the lab result, not the patient.
I'm just not convinced by that line of reasoning because it prioritizes social comfort over biological safety. The stigma is only there because we don't talk about it. If we normalized knowing your status, the stigma would vanish. The Healthline and CDC sources emphasize the 5 Ps of sexual health:
Partners, practices, protection, past history, and pregnancy prevention.
Right. Ignoring the virus prevents the past history conversation. If you know you have HSV2, even if you're asymptomatic, you can take valacyclovir. You can reduce the risk of giving it to your partner. To me, that is ethical medicine. Protecting your partner is part of the responsibility of being sexually active.
But at what cost? You're asking millions of people to take daily antiviral medication for a condition that causes them zero physical symptoms. And let's talk about the Health Direct source from Australia. They emphasize that while antivirals help, it's the stigma that is the primary source of distress. Psychologists are often needed to help patients work through the diagnosis. If we stopped hunting for it in asymptomatic people, we would eliminate that psychological trauma. The virus isn't hurting them, the diagnosis is.
The virus is hurting the people they transmit it to. That's the disconnect. You're focused on the carrier, I'm focused on the community. And regarding its benign nature, we have to remember that HIV transmission is easier in the presence of HSV. It's a cofactor.
That's true, but again, we're talking about risk stratification. In a high-risk population, perhaps the calculus changes. But for the general population, the priority health and BCBS policies reflect the reality that we cannot and we should not attempt to sterilize the human body of every single viral passenger.
So let me bring us back to the lichen sclerosis issue, because I think it perfectly highlights the danger of your benign means benign philosophy. We talked about systemics, but let's talk about the diagnostic delay. The University of Kansas Health System source mentions that vulvar disorders are frequently misdiagnosed. A patient presents with itching. The conservative doctor says, oh, it's just a yeast infection, or it's just dermatitis. They prescribe a cream and send them on their way. Meanwhile, the LS is actively scarring the tissue.
Okay, but a misdiagnosis is a failure of clinical skill, not a failure of a conservative philosophy. I agree we need better education, but the solution isn't to biopsy every itch. It's to recognize the clinical signs, the white plaques, the crinkled paper texture.
Which you only recognize if you're looking for them and if you have a high index of suspicion. The Next Steps in Dermatology source explicitly says we need to lower the threshold to discuss starting systemic agents in pre-scarring conditions. That's the definition of proactive. Pre-scarring, you want to treat it before the damage is done. Your approach waits for the damage to justify the treatment.
My approach waits for the disease activity to justify the risk of the treatment. There is a critical difference. If a patient has mild LS that is controlled by topicals, putting them on methotrexate is malpractice. It's just overkill.
And if the topicals aren't working, the source says up to 43% of lichen planus patients require systemic agents. That is nearly half. If you are a conservative clinician, you might keep trying different creams for years while that patient loses function.
That's a fair point. In refractory cases, escalation is necessary. But let's look at the herpes paradox again. You mentioned suppressive therapy. Medline Plus notes that one way to take the medication is only when symptoms occur, so episodic therapy. This avoids the cost and the burden of a daily medication. Why isn't this a sufficient middle ground?
Because episodic therapy does nothing for asymptomatic shedding. It treats the sore, not the transmission risk. If you're in a discordant relationship where one partner has it and the other doesn't, daily valacyclovir reduces transmission by nearly 50%. Combined with condoms, it's highly effective. Episodic therapy is for the patient's comfort. Suppressive therapy is for the partner's safety.
And yet, condoms don't cover all the areas. Healthline and Medline Plus both remind us that the virus can shed from areas not covered by a condom, so we're offering a false sense of security.
No, we're offering risk reduction. Nothing is 100%, but doing nothing is 0% reduction. We have to be realistic.
It does. I'd like to summarize my perspective. While malignancy and severe symptoms absolutely require action, the medical community, and yes, the insurance policies rightly restrict the removal of truly benign lesions. We must stop pathologizing the normal human body. Millions of us carry viruses like HSV. Millions of us have skin tags or keratosis. Urging listeners to let go of the fear of what if isn't negligence, it's wisdom. Don't let the anxiety of a dormant virus or a harmless bump drive you to unnecessary procedures or a lifetime of medication. And I'll leave you with this. The skin is a window to our systemic health.
Whether it's the hidden cancer risk of lichen sclerosis or the silent transmission risk of HSV, knowledge is power. Benign is a histological term, not a quality of life guarantee. Proactive management, including biopsy when uncertain, and antivirals when appropriate, empowers patients and protects public health. We should not wait for a scar or a transmission event to finally act. Thank you for joining us on the debate. We hope this discussion helps you view your own medical choices through these competing lenses of vigilance and acceptance.
There's always more to explore in the material, and we encourage you to look at the evidence yourself. Until next time.